Hello everyone and welcome to my channel. Today's video is on ventilator mechanics and PRVC. I wanted to make a video explaining PRVC and talking about it. It's kind of a contentious mode, like there's a lot of debate around it. A lot of people love it, a lot of people hate it, that kind of thing. It's very divides people a lot. But in order to talk about that, in order to understand how PRVC works, and in order to kind of understand some of the marketing behind it, some of the claims that people push about it, we have to first understand basically our respiratory mechanics and how a ventilator delivers a breath. So the first part of this video is going to be about basically ventilator mechanics and breath delivery, and then the second part is going to be about PRVC, what it actually is, how it works, the advantages, disadvantages, and kind of some of the discourse regarding it. Okay, so as always, we have our objectives here. So first of all, we're going to understand the basic mechanics of breath delivery. We are going to describe the relationship between flow, volume, and pressure. That's a really important one. We are going to evaluate the relationship between the equation of motion and breath delivery. That's a big one as well. And we are going to explain PRVC mode in relation to ventilator mechanics and breath delivery. We are also going to kind of compare it to traditional VC and PC modes as well. And once again, just talk about various aspects of PRVC. Spontaneous ventilation. So these are negative pressure breaths. Basically, there's a contraction of inspiratory muscles, and that will expand the thorax. That will decrease intrapleural pressure, which will then decrease alveolar pressure. And this creates a pressure gradient between the alveoli and the airway opening. The pressure at the airway opening is now more positive than alveolar pressure. Nature hates a gradient, so air will now flow into the alveoli and fill them with a tidal volume in order to equalize the pressure between the airway opening and the alveoli. That's basically how spontaneous breathing and how negative pressure ventilators work. Now let's talk about positive pressure ventilation. In this case, the pressure gradient is reversed. The vent creates positive pressure at the airway opening. Airway opening pressure is now more positive than alveolar pressure. Once again, nature hates a gradient. Air flows into the alveoli and fills them with a tidal volume. The vent can control various elements of how gas flows into the alveoli, but it can't control all of these elements at once. That's an important point that's going to come up again later. So now we're going to talk about the relationship between flow, volume, and pressure. This is the most vital relationship in pulmonary mechanics. So volume is essentially the amount of gas that occupies the lungs, typically measured in milliliters or sometimes in liters. Flow is the movement of said gas, basically how quickly the gas is delivered. And pressure could mean a lot of things. When it comes to mechanical ventilation and just respiratory mechanics, there are a lot of different pressures, okay? But we need to remember Newton's third law of motion. See, you thought I was going to bring up some gas laws here, but I'm not. I'm bringing up just laws of physics, right? Every action has an equal and opposite reaction. I honestly believe that this third law of motion is maybe even more important than the gas laws when talking about respiratory mechanics, right? Let me explain. So basically, when the ventilator delivers a volume to the lungs, that volume is going to stretch the alveoli, which creates a pressure. That pressure is then exerted back onto the ventilator, and this can be measured as the plateau pressure. How much pressure is created by the stretch and created by that volume is a product of elastance and compliance. Compliance is essentially the ability for the lungs to stretch, and elastance is the ability for the lungs to recoil. They're essentially inversely related to each other. Now here's another thing, all right? So the vent delivers a tidal volume to the lungs. That flow of gas experiences friction, and that causes resistance as it moves. This resistance also generates a pressure which is then exerted back on the ventilator. The pressure created by the alveolar stretch plus the pressure created by airway resistance is basically your peak pressure. Now, to expand on that a little bit, a slower flow of gas means less airway resistance, and the reverse is also true. A bigger volume filling the alveoli means more stretch, more pressure exerted by that volume, and more pressure exerted back on the ventilator, and vice versa. Lung and chest wall compliance is going to determine how much pressure is exerted by a certain volume. The resistance and diameter, basically, of the airways and endotracheal tube will determine how much pressure is exerted for a certain amount of flow. If you have a wider tube, a wider airway, there is less resistance to a certain amount of flow. Gas density also plays a part in resistance, but that's really only relevant in the context of heliox, and we're not getting there yet, so don't worry about that one. So now, the equation of motion. This is one of my favorite equations in respiratory care. So here you have Pmus plus Pvent is equal to resistance times flow and elastance times volume. You have basically the movement of the gas, and then you have the filling of the lungs. Those are the two things that create your actual ventilation, right? And those are the two elements that the ventilator and the patient have to overcome. The left side here, Pmus and Pvent, describes the pressure required to generate ventilation. Pvent is the pressure delivered by the ventilator, and Pmus is the pressure generated by the patient's respiratory muscles. The relative contribution between these two depends on many factors. For example, if your patient is paralyzed, Pmus is 0, right? There is no inspiratory effort on behalf of the patient. If you have a patient on, spontaneous pressure support and they're on a pressure support of 0, then Pvent is also 0. It's giving 0 support, right? This is another thing that's going to be relevant later. Keep this equation of motion in mind, just conceptually what it means, right? It means you have the patient and the ventilator working together to generate volume, basically. And how hard they have to work is determined by resistance times flow and elastance times volume. So compliance, there are two types of compliance. We have static and dynamic. Typically, if somebody just says compliance without specifying, they're typically talking about static compliance in general, as that one is kind of more, I'm not going to say more important, but it's possibly the more important one. So static compliance is your tidal volume divided by plateau minus PEEP. This is a measure of the compliance of the lung parenchyma and chest wall. Basically, how easy it is to fill the lungs, how much basically pressure you need for a given unit of volume. And dynamic compliance is tidal volume divided by peak pressure minus PEEP. This is basically a measurement of airway resistance and lung compliance combined, right? If you basically take the difference between your plateau and your peak pressure, that's going to give you essentially what your airway resistance is. So dynamic compliance is kind of less specific, because it does kind of tell you about your lung compliance, but it's also mixing it up with airway resistance too. You can't really tell anything just by looking at dynamic compliance. You have to look at the separate elements, right? And then finally here we have my favorite, driving pressure is plateau minus PEEP. This is the actual amount of pressure needed to deliver a certain volume to the alveoli. And real quick, something I want to mention while we're here, when we are talking about something being quote-unquote lung protective, we are always talking about plateau and driving pressures. We're talking about keeping plateau under 30. We're talking about keeping driving pressure under 15. Peak pressure really is not part of the equation when we're talking about being lung protective or talking about barotrauma. That's going to come up again later as well. Just keep that in mind. When we're talking about compliance, static is really probably the most important one. So now we're going to talk a little bit more about positive pressure ventilation. The ventilator will deliver a flow of gas to the lungs for a certain amount of time. This is the I time. This flow of gas creates a volume which stretches alveoli and exerts a pressure. That flow of gas also creates airway resistance, which also exerts a pressure. Now that's basically just summing up what we just talked about a couple slides ago, right? Now you can control 2 to 3 of those 4 things at the same time at the most. And in spontaneous modes, like say pressure support or CPAP mode, you control even less of those things. You're typically really only controlling one variable, or sometimes you're really not controlling anything at all. But we're really just going to be talking about typical assist control, like full support types of modes here. So in volume control, you can control how much flow is given for how long, which will give a certain volume total. And the pressures generated by that flow and that volume will vary. Both the pressure of airway resistance and the driving pressure, meaning basically your static compliance, those are both going to vary. Most ventilators in traditional volume control, you're going to set the flow, and basically flow and I time are basically fixed variables. If you change one, it changes the others in volume control. Because think about it, if you have a flow, let's say you have a flow of 60 liters per minute and an I time of 0.5 seconds. 60 liters per minute, that means 1 liter per second. With an I time of 0.5 seconds, you get a total volume of 500, right? Well, if you set your volume at 500, you can change, the flow, but if you increase the flow, you have to shorten the I time. If you decrease the flow, you have to increase the I time, right? Some ventilators, like say servo ventilators, you actually set I time instead of flow. But once again, same thing. You change the I time, the flow is going to have to change because the volume is fixed. And the ventilator doesn't care about what pressure that flow and that volume is generating. Meanwhile, in pressure control, you control the inspiratory pressure and the inspiratory time, but the flow needed to reach that pressure and the resulting volume will vary. Basically, the ventilator is going to say, okay, I'm going to make pressure of 14 at the airway opening, and I'm going to hold that pressure there for 1.2 seconds, let's say. And then basically the amount of flow that is generated is going to be determined by the airway resistance and the lung compliance. That's basically how pressure control works. The vent does not care about the resulting volume. You can hypothetically control the pressure, meaning peak pressure, and the tidal volume at the same time, but the flow and the I time needed to reach that pressure will have to vary based on airway resistance. What I mean is that slower flows mean less airway resistance. And peak pressure has to do with airway resistance, right? So if you give a slower flow and a longer I time, you can decrease peak pressure and still get the same volume. But that is specifically peak pressure, not plateau pressure. Your static compliance, meaning how much tidal volume you get for a certain driving pressure, that varies solely based on how well the alveoli and chest wall can stretch. In other words, you cannot control tidal volume and driving pressure at the same time. Those two things, there is nothing that you can do. There's no way that the ventilator by itself can magically improve static compliance, right? There's nothing you can do to do that. We'll talk a little more about that later. So now we're on to the second part of the video. PRVC, what's in the name? So PRVC is the name for a mode of ventilation on the servo ventilators, and I believe also some GE ventilators and the Avia as well. I don't actually know who owns the trademark or if anybody does. I think maybe the people in charge of servo do. I'm not 100% sure. But it's basically like a trade name for a certain mode. But that is basically the most commonly used name for what is now referred to generically as adaptive pressure control mode. This is kind of the new age name that researchers and other professionals have adopted for what we typically in the field call PRVC. What is it called on other ventilators? It's called volume control with autoflow or pressure control volume guarantee on Draegers. It's called APV CMV or SCMV plus on Hamilton vents, and it's called VC plus on Puritan Bennett vents. So you can see that all of these different ventilators have very different names for PRVC. Now, this mode does work slightly different on each of these vents, but it has essentially the same function across the board. What I mean is, for example, the kind of feedback loops and pressure regulation mechanism varies from vent to vent very slightly. Like some of the vents, the inspiratory pressure is going to be limited to 10 under the high pressure limit, and on some vents it's 5 under the high pressure limit. Some ventilators are going to titrate your inspiratory pressure by 1, some will titrate it by 2, etc., etc. So very slight differences, but not really a huge difference in how it works. So I said at the beginning of this video that PRVC is kind of a point of contention for a lot of people. So why is PRVC so contentious? Well, it is commonly used but poorly understood as a mode of ventilation. What the ventilator in PRVC is basically trying to do is it's attempting to control the pressure and the volume at the same time. Now, is that possible based on what we just learned about? I want you to think about that. It is often marketed as delivering the volume using the lowest possible pressure and being lung protective, whatever that means. But many clinicians dislike PRVC as it has a high risk for patient ventilator dyssynchrony. Now here's the question. Is it really detrimental or beneficial to the patient? Well, we're going to get into that. Really, my biggest point of contention here is not necessarily the dyssynchrony thing, it's the marketing. It's the basically they make it sound like this magical thing where somehow your compliance is going to be better. Like you're going to get volumes, you're going to get the same volumes using less pressure. Well, yes, but no. We're going to talk about that. Okay? So on a mechanical level, how does PRVC work? Well, let's look at the settings you can set. You can set your respiratory rate, you can set your tidal volume, your I time, your PEEP, your FiO2, and your trigger variable. So it basically looks like volume control. It looks like volume control on the servo, where you set I time instead of flow. But it basically looks like volume control, right? Well, how does it actually work? Here's the easiest, most simple explanation of PRVC, okay? The ventilator is attempting to use pressure-controlled breaths to deliver a targeted tidal volume. It is attempting to do volume control using breaths with a set inspiratory pressure, okay? Let that sink in. Now, here's how it works. In traditional PRVC, I don't know if every PRVC mode on every ventilator is like this, but at least on the servos, traditional PRVC, the first breath delivered is a volume-controlled breath. The vent is going to go, okay, you set a tidal volume of 500. I'm just going to, boom, there we go, give 500 real quick. And then the vent is going to determine what inspiratory pressure is needed to deliver that tidal volume. It's going to go, okay, I gave 500 and I got a plateau pressure of 19 and I'm on a PEEP of 5, so I need an inspiratory pressure of 14 to get there. So after that first breath, The subsequent breaths are pressure-controlled breaths, meaning instead of a fixed tidal volume with a fixed flow, it is going to be delivered with a fixed inspiratory pressure and a variable flow. So the vent is kind of guessing. It's going, okay, well, last breath I needed inspiratory pressure of 14 to get 500, so I'm going to give 14 again, and let's see if I get 500 back. The vent is then going to adjust inspiratory pressure each breath in order to reach the targeted tidal volume. Hence the generic name adaptive pressure control. Let's say lung mechanics change. All of a sudden, it gives an inspiratory pressure of 14 and it only gets back 450. The vent's going to go, oh, I'm not reaching my targeted tidal volume. Next breath, I'm going to give an inspiratory pressure of 15 and see what I get. And the next breath, it gives inspiratory pressure of 15. It gets back a tidal volume of, 480. And it goes, okay, I'm still not quite there. Next breath, I'm going to give inspiratory pressure of 16. So it's going to just slowly titrate and try to reach that targeted tidal volume. Right here, saying basically what I just said, as resistance and compliance changes, the vent will have to adjust the inspiratory pressure to achieve the targeted tidal volume. Your inspiratory pressure is limited by the high pressure limit set by the operator. So your peak pressure alarm, your high pressure alarm, that limits your inspiratory pressure. Some vents are going to limit the inspiratory pressure to 5 below that alarm. Some vents are going to limit it to 10 below. But that's basically, so your high pressure limit is almost like another setting on the ventilator, because that's basically your maximum inspiratory pressure setting. But your inspiratory pressure could be anything under that. Now, because these are pressure-controlled breaths, because they have a set inspiratory pressure, they have a naturally decelerating flow pattern. This causes lower peak pressures than volume control, hence the claim that it's delivering you the tidal volume with the lowest possible pressure. That's where that claim is coming from. And it's technically not wrong, but they mean lowest possible peak pressure. So pressure advantage, this is what I'm talking about. PRVC will achieve lower peak pressures than volume control for the same volume. However, your plateau pressure, your driving pressure, your static compliance will all be the same as in volume control. So here's the question. Is that really more lung protective? Think about it. Now, peak pressure. This is the highest measured pressure in the respiratory system. Now, I want you to think about, where is the highest pressure usually located at? It's located at the point, now think about peak pressure. Once again, it's airway resistance plus lung compliance. Lung compliance is at the measure of the alveoli. Airway resistance is obviously at the level of the airway. So the narrowest point of the airway is going to have the highest resistance. So let me ask you something. Have you ever heard of somebody blowing a main stem bronchus? Have you ever heard of somebody blowing out an ET tube because the peak pressure was too high? How about blowing a pneumothorax? Have you heard of that one? Let's think about it. Does that happen at the level of the ET tube? No. Does that happen at the level of the main stem bronchi? No. Where does that happen? That happens at the level of the alveoli. Now let me ask you, what is a surrogate for pressure at the level of the alveoli? Plateau pressure. What is the pressure used to fill the alveoli? Driving pressure. High driving pressure and high plateau pressure is what leads to barotrauma. That's what leads to pneumothoraces and that kind of stuff, right? Not high peak pressures. I cannot find any evidence that shows high peak pressures independent of plateau and driving pressures as increasing mortality. Now, I'm not saying high peak pressures are good, okay? I'm not trying to sit here and tell you, not to care about peak pressures. Obviously, peak pressures are still important to monitor, but if we're talking about being lung protective, if we're talking about mortality, if we're talking about ARDS, whatever, we are talking about driving pressure. We are talking about plateau pressure. We are not talking about peak pressure, okay? The claim that PRVC leads to lower pressures for the same volume is very misleading. It is not false, but it is misleading, okay? And anyone that tells you that PRVC is more lung protective because it's giving the lowest possible pressure, I don't think they understand what lung protective actually means. Sorry. So that right there, I'm not going to say that whole lower peak pressure thing, like that's not a bad thing. Once again, I'm not saying lower peak pressure is bad. That's a good thing, okay? But is it really a huge selling point? Should it really be a huge selling point? Probably not, okay? So what actually is bad about PRVC? Well, here's something that's bad. Let's first recall the equation of motion. You have basically the patient effort, P mus, and the ventilator effort, P vent, to generate tidal volume. Now let me ask you a question. What happens when the patient becomes dyspneic? The patient's inspiratory muscles generate negative intrapleural pressure, which increases the pressure gradient between the alveoli and the airway opening. At the same time, the ventilator is going to deliver a set inspiratory pressure. The pressure gradient is now larger than normal because of P mus. Normally, passively ventilated patient, you have alveolar pressure of, 5, and you have an inspiratory pressure of, 19, let's say, like 14 plus 5, right? So you have a pressure gradient of 14. Well, what happens is when the patient's effort increases, now they're starting to do this. Now, remember, with the negatively ventilated patient, that expansion of the thorax is going to drop intrapleural pressure. And so now, instead of the pressure at the alveoli being 5, which is our PEEP, now the pressure might be -2 or something, right? Depending on how much effort the patient is generating. So now there isn't a gradient of 14. Now there's a gradient of 21. So the delivered volume is going to be bigger because there is now a bigger gradient between the airway opening and the alveoli. In traditional pressure control, nothing else happens. The patient just pulls a bigger tidal volume. If they're dyspneic, they're going to get more flow. They're going to get more volume. Now, what happens with the PRVC vent? The PRVC vent goes, oh, I delivered an inspiratory pressure of 14, and I got back a tidal volume of 850 instead of 500. Well, I guess it's time for me to decrease the inspiratory pressure so I can get the volume back to 500. The vent then decreases the inspiratory pressure delivered to the patient, and thus decreases the support given to a patient in respiratory distress. Do you understand how torturous that is for an air-hungry patient? Okay, you're smothering them. They are air-hungry. They are craving more support, and the ventilator is giving less and less and less support. This is going to increase the patient's oxygen consumption, their CO2 production. This is going to increase their work of breathing, right? This is going to cause all sorts of problems. They want more, the ventilator is giving less. This is way more dangerous than any other, so-called disadvantage of PRVC or whatever. This is very, very bad, potentially. Now, traditional volume control can have a similar problem. The flow is fixed, right? It gives X flow for X time to give X volume. Basically, as the patient's muscular effort increases, peak pressure is going to decrease. Plateau pressure is going to decrease, basically, but tidal volume is not going to increase because the flow is set. The patient is locked out. They get exactly the flow that the ventilator delivers. Now, most modern ventilators with volume control have adaptive flow, meaning if the patient wants to take in a bigger breath and more flow, they can. But some, for example, the Servo U that I use is really finicky. and it only gives adaptive flow on a square flow pattern, not decelerating or anything else, and only if it's like 100% square flow pattern. And also, it only gives adaptive flow on mandatory breaths, not on spontaneous breaths. So if your mandatory rate is set low and they're breathing over that spontaneously, they're going to be double triggering all the time because they want more flow and the vent's locking them out. So just little word of advice: if you use a servo U in volume control, you got to set the rate to match their intrinsic demand if you want that adaptive flow, and it only works with square waveform. Anyway, that was kind of maybe not super relevant, but I'm just trying to get you to understand patient dyssynchrony. Volume control can have problems with dyssynchrony. PRVC definitely can as well. Pressure control generally tends to be a lot better because the patient can pull whatever flow they want. Sometimes the inspiratory pressure might not be enough, though sometimes they might actually need more. PRVC is going to do the polar opposite. It's going to decrease inspiratory pressure when your patient becomes tachypneic and dyspneic and flow hungry. Very, very bad. So moving on, let's talk about what kind of mode is PRVC. And this is a question that sometimes I'm bringing this up because sometimes you get asked this question in interviews. Sometimes they'll ask this question at school or whatever. It's kind of a hot topic. Now, we used to refer to, and by we, okay, not me, but researchers used to refer to PRVC as a dual control mode. And the reason they did is because it's trying to mimic volume control, but giving pressure-controlled breaths. But nowadays, the researchers say, well, actually, it's a pressure control mode. And technically, it is. All right? Each breath is delivered with a set inspiratory time and inspiratory pressure. That is the definition of pressure control. Flow and volume vary. That is pressure control, technically speaking. Technically is pressure control. However, your inspiratory pressure changes breath by breath. Are you really controlling the pressure, driving pressure, if the vent can change it each breath? If I put my vent on pressure control with an inspiratory pressure of 14 and walk away, I know when I come back that the driving pressure is going to be exactly the same. If I set it on volume control to a volume of 500 and I get a plateau pressure and I see I have a driving pressure of 14 and then I walk away, when I come back my driving pressure could be different. Same thing goes for PRVC. Because I'm not setting the inspiratory pressure, I'm setting the volume. The ventilator is determining the inspiratory pressure. You can limit, once again, you can limit the driving pressure with your high pressure limit, but most of the time high pressure limit is set by default to like 40. If you set your peak pressure alarm to 40, then it's 5 to 10 below that. But you're still talking about a driving pressure of like 25. You're still talking about a plateau of 30, which is, acceptable, but that's a high driving pressure. Unless you're setting your high pressure limit to like 20 or 25, depending on the ventilator, you're really not controlling the driving pressure, are you? No, you're really not. Few questions here for you. What is the clinical goal of pressure control? As in, I have a patient, they are intubated, they are here for this problem. You want to put them on pressure control. Why? Well, you would put them on it because, first of all, it tends to be a little more comfortable. But second of all, you can control the driving pressure. You can control the plateau pressure. And the patient can take in whatever volume they want. Now, yes, your CO2 clearance will be a little more variable. That may or may not matter depending on who the patient is and their acid-base status and that kind of stuff. What is the clinical goal of volume control? Why would you put a patient on volume control? You would put them on volume control generally because they need a stable CO2 clearance. Now, what is the clinical goal of PRVC? Why would you put a patient on PRVC? Well, it's a pressure control mode, right? Technically speaking. So would you put them on it to limit their driving pressure? Once again, no. No, because the vent is changing the driving pressure each breath. You're not controlling that at all. But what are you setting? Well, you're setting tidal volume. So really, if you think about it, the goal is very similar to the goal of volume control. You are trying to get a stable minute ventilation. And here's some food for thought. If PRVC is technically, according to the experts, a pressure control mode, why do many manufacturers refer to it as a form of volume control? Why is it called pressure regulated volume control by the folks at Servo? Why is it called volume control plus on the PB machines? Why is it called volume control with autoflow on the Dragers? Maybe because even if it's giving pressure controlled breaths, it functions more like a volume mode. How do I apply PRVC conceptually? Clinically, the goal is to control, once again, the tidal volume and thus the minute ventilation, allowing for more stable CO2 clearance. If it is to be used, it should be applied in a similar manner to volume control. If the patient becomes desynchronous, you should immediately switch them to another mode, okay? Because once again, it's going to activate that feedback mechanism of increasing dyssynchrony. Do not use PRVC in lieu of pressure control. It does not have the same advantages as pressure control. At least, I mean, it kind of has some of them, but like not really, okay? The only real advantage of PRVC versus volume control, besides the peak pressure thing, is that you have the ability to drag out the eye time without causing flow starvation. And it may also be more comfortable in an already synchronous patient because pressure-controlled breaths are just more comfortable. They have that naturally decelerating flow. So hypothetically, PRVC is more comfortable than volume control as long as your patient doesn't become air hungry. The second they become air hungry, PRVC is terrible. Now, the patient may still not tolerate a long eye time, and they still might set off that feedback mechanism of increasing PMUS and decreasing PVent. So you really have to keep an eye on them, which is ironic because it's kind of seen, it's kind of marketed as set and forget. Oh, well, the vent is automatically going to do the work of giving the lowest possible pressure and being lung protective, so I can just set my tidal volume to, 5 mils per kg and just walk away and it'll be fine. But if your patient becomes air hungry, they're in trouble, right? You're putting them in a very bad place. The reason why I talk so much about kind of is it a volume control mode, is it a pressure control mode, is once again, people will tell you now, oh, it's not a dual control mode. That's wrong. It's technically a pressure control mode. And I got into a debate with a guy about this actually because he said the same thing. Well, according to the equation of motion and the taxonomy of ventilator modes, it's a pressure controlled mode. And I'm like, yes, like from a technical standpoint, it's giving pressure controlled breaths. Sure, you're not wrong, but you're really not controlling the pressure. The whole goal of this is the same goal as volume control. In the hospitals I have been to where they use PRVC, they use it the same way you use volume control. Okay? Clinically, it is a volume control mode. Okay? Do not get it twisted. Do not treat this like pressure control. It is not pressure control. So, summary here. PRVC is basically attempted volume control using pressure-controlled breaths. The inspiratory pressure is titrated via a feedback mechanism based on the exhaled tidal volume. So PRVC is kind of like a less accurate volume control because the vent will give the inspiratory pressure and it might overshoot by a little bit, right? With volume control, you are going to get pretty much exactly the tidal volume you set. There might be some variance due to, compliance of the circuit or leaks or whatever, but you're basically going to get that 500 that you set. With PRVC, you're going to get like close-ish to that 500, but the vent might be like titrating up and down and all over the place to try to keep it at 500. PRVC, in my opinion, is neither inherently good nor evil. it is not this amazing miracle mode like some people seem to make it out to be, but I also don't think it's the devil, and I think in the right circumstances it's totally okay. It has a fixed tidal volume like volume control, which means stable CO2 clearance. Pressure-controlled breaths means lower peak pressure and potentially longer I times than volume control. This is a good thing, but it is not the same thing as being lung protective. It is not any more lung protective than volume control. Don't get it twisted. Switching modes will not improve your static compliance. As I was talking about earlier, only increasing mean airway pressure in a recruitable lung can do that. That is the only way you will actually improve static compliance, is if the patient's lungs actually get better and you recruit more. And you can do that in any mode, essentially. Some modes are better for it than others, but you can do that in any mode. Extreme caution must be used so that the patient does not become dyspneic and air hungry and trigger the feedback mechanism. And this mode is generally praised by people who don't fully understand it and vilified by people who do. Now, I'm not saying that means PRVC is bad. I'm not saying that you should or should not use it. I am just saying that a lot of the times when I've seen praise of PRVC, it's people claiming that it's more lung protective and it's great because it's automatically titrating the pressure. That's really not an advantage. You know, is it a bad thing? Like, no, of course not, but that's not the flex that you think it is, okay? I had somebody try to say, well, you know, isn't it better in a patient with variable lung mechanics, you know, like ARDS that's improving or getting worse because it can titrate pressure breath to breath? No, it's not, because in volume control, the vent is not having to titrate anything. It's just delivering X flow for X amount of time to get X volume. It doesn't care what the pressure generated is, okay? But it doesn't have to do any calculations. It's just going to do that, and it's going to happen. In PRVC, the ventilator is going to have to calculate, oh man, I didn't get the volume I need. I have to titrate the pressure up, right? The vent has to adapt the pressure, and people they market that as if it's some kind of benefit, that it's adapting the pressure. Well, volume control is adapting the pressure too, but it's doing it automatically based on the patient's lung mechanics. Like, yeah, it's adapting the pressure too, because the driving pressure is going to be determined by the static compliance. Like, what are we talking about, right? Like, this doesn't, it's just, yeah, no. People that say that are and I'm not trying to disparage anybody, okay? I'm not trying to make fun of anybody. You know, it's okay if people don't understand these things, but to sit here and say that it's some sort of huge advantage when it's not, it's just being misleading. It's really, really misleading, that's all. Anyway, demo time. As always, I'm going to get into actually visually seeing these modes so we can see what's going on. Okay, so here we have our Hamilton ventilator, Hamilton Ventrainer. Oh boy. So, let's start out with good old-fashioned SCMV, which is volume control. So we're going to start with some pretty bog standard settings. We're going to do a rate of 12, we're going to do tidal volume of 500, PEEP of 5, 50% with a 0.9 I time. Flow pattern, let's just do square just to kind of like show how that works. And let's go off to the races and ventilate. Here we have our volume control ventilator. We can see that the ventilator is delivering a set flow for a set amount of time. Our peak pressure, this is our square waveform or constant flow. We have increasing peak pressure. Now what's happening here is as more flow and more volume fills the alveoli, plateau pressure rises. Now, airway resistance stays the same because we have a constant flow. The air is always flowing into the lungs at the same speed. So airway resistance stays the same, plateau pressure rises, and thus peak pressure increases over the course of the breath as more and more volume fills the lung. If we drag out the I time, let's drag it out to 1.4, we're going to see our flow drops significantly. Our peak pressure is a bit lower too, because now our flow is lower, so our airway resistance is lower. Now plateau pressure is still rising, but there is now less airway resistance. But with volume control, we can never get our airway resistance to 0. We can see our plateau is 14, right? There's a difference of 3, basically 3 centimeters of water of airway resistance. We have driving pressure of 8. We have a static compliance of 60, right? PEEP of 5. Now, lowering your flow like this, tell me, inspiratory flow, 21.4, that's kind of low. Now, I'm not going to say your patient needs any specific set flow. You should set flow to be above their inspiratory demand, right? And maybe their inspiratory demand is only 15. Maybe a flow of 20 is fine. But that's up to you to determine. So now let's shorten the I time. So we're going to see we now have a higher flow because we're giving the same volume in less time, which means we need more flow. We can see there's a sharp increase in our peak pressure. We can see there's now a difference of 6, right? There is more airway resistance. But at the level of the alveoli, nothing has changed. Our plateau pressure is still 14. Our driving pressure is still 8. Our static compliance is still 60. Nothing has changed in regards to lung protection or whatever. The only thing that's changed is that our peak pressure is now higher. We're delivering the same volume over a shorter amount of time. Right? We can go even lower, whatever. Well, let's keep it at 0.8 for now, and let's change the flow pattern. Let's go for completely decelerating flow. So, what's going on here now is that the ventilator basically determines, okay, in order to get a volume of 500 with this flow pattern, I'm going to have to do blah, 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 blah. Like, it's essentially doing calculations. It's still giving X flow over X amount of time, but instead of delivering that flow constantly, it's going to start by delivering the flow really fast, and it's going to titrate the flow down as the volume is delivered. This is not the same thing as decelerating flow with pressure control. That is actually very, very different because that happens naturally because the ventilator is not controlling the flow. Basically, it's only controlling the pressure. In this mode, the ventilator is controlling the flow. It is artificially creating this decelerating flow, so you still have this high peak pressure. And same thing if we go to, say, the not quite as decelerating flow, right? And what you can see here is that our pressure is still not constant. Our pressure is still changing as the flow changes. And same thing you might have noticed with the completely decelerating flow, our pressure actually kind of dipped down. But it was basically the same thing, right? Our pressure is still not constant. No matter what we do, our pressure is not going to be constant here. But let's look. Okay, our airway resistance, exactly the same. Our driving pressure, exactly the same. Our static compliance, exactly the same. The only thing that's changed is how it looks. And this might maybe be more comfortable for the patient because it does kind of mimic a little more how the patient actually breathes, but Okay, so now let's do something different. But okay, let's try to mimic a tidal volume of 500 with pressure control. Let's just see what that looks like. So we would want a pressure control of like 9, I think. And the I time definitely a little longer. I'm not going to go super long, but I'm going to go like 1.2, which is pretty decent. I'm going to leave everything else the same. Now let's look at this. Let's see what volumes we get. what is that? Close to 500. Close-ish. Now, what's happening here? Our peak pressure is a lot lower. Right? Peak pressure is a lot lower. Now look at our flow waveform. It's decelerating, but it's not quite decelerating like the way it was in volume control, right? Because in volume control, once again, the ventilator is controlling the flow. It's controlling how much flow is being delivered to the patient. I'm actually going to bump this up a little more. Like 1.5, because we're not quite there. But, you know, anyway, the ventilator is controlling the flow in volume control mode. So it has to artificially create that flow pattern. With here, in this mode, the reason why flow is decelerating is because the pressure at the airway opening is constant. And there's a pressure gradient between the airway opening and the alveoli. And at first, that's a really big gradient. Now, as basically there's this big gradient, so the air starts to flow into the lungs and fill a volume. That volume exerts a pressure back on the lungs. Now, as the pressure at the alveolar level increases, the difference between airway pressure and alveolar pressure decreases. As that difference decreases, the flow decreases, right? Until eventually the flow, if we drag this out long enough, the flow will eventually hit 0. And please don't put your patient on I time of 2.4. I'm just doing this to demonstrate. Eventually that flow is going to reach like 0, basically. Right? You see that there. The flow is basically reaching 0 because the pressure at the alveolar level is the same as the pressure at the airway level. And we can see that because our peak and our plateau are the same. They're both 14. Now let's look at something here. Driving pressure is now 9. Now that's slightly higher than it was in volume control, but that's because we set inspiratory pressure to 9. If we set it to 8, driving pressure of 8, and look, tidal volume is close, pretty close to 500. Not quite exactly. It's like, we're like kind of close-ish. It's always going to be off a little bit. But let's look at what's more important, static compliance. Has our static compliance changed at all? No, it is basically exactly the same. Our driving pressure is exactly the same. Our static compliance is actually the same. Our plateau pressure is exactly the same. See, we can't get exactly 500. We either get like 470 or like 520, basically. Because it's pressure control, it's not volume control. You can't get exactly the volume you want, but you're going to get close to it, right? Our plateau pressure is the same. We're getting similar volumes, and our compliance is the same. It is the same, right? Basically, nothing has changed. Our peak pressure is decreased, okay? But that's it. So here's our volume control. Tidal volume of good old 500. Once again, plateau of 14, driving pressure of 8, static of 60, peak of 19. Let's try PRVC. Let's try PRVC. Same settings. I'm not going to change anything. I'm going to keep it exactly the same. Confirm. Okay. So first, watch what the ventilator is doing. So our peak pressure, so it's giving, look at this. This is constant pressure, decelerating flow. This looks like pressure control, right? It looks exactly like pressure control. It's pressure controlled breaths. Now what's happening right now is the ventilator is giving an inspiratory pressure of 11, basically. And it's getting back volumes in the high 600s. Now, I think this might actually be like an error with the software or something, because I think it should be doing kind of like what the servo does, where the first breath is volume control, and then it sets inspiratory pressure off of that. Because as you can see, I set it to 500, and we're getting way over that still. I mean, it's coming down now. You can see the vent is slowly titrating pressure down. It went from 20, 19, 18, 17, now we're at 16, right? You can see the pressure is getting lower, and our volumes are getting closer. But you can see that it way overshot it. the pressure and the volumes were way too high at first, and now it's backing off. And now we're getting back closer to 500. 515, 499, like, okay, right there, we're pretty good, right? It is trying to do volume control with pressure-controlled breaths. And as you can see, it's kind of sloppy, right? Because they're pressure-controlled breaths, you're not going to get the exact volume. You're going to get maybe close to it, but it's not going to be exact. See, right now, we're at like 470. That's pretty much right where we were in pressure control. Okay? And now what it should do is it should titrate up a little bit more to try to get back to 500. Watch this. In a few breaths, it'll do it. I promise. Promise. There we go, 16. Yeah, okay. So it titrated up to 16, and now it's like, okay, I'm close. I'm close to that. I'm right around 500. It titrated down a little too far, and it titrated back up. Now we're getting right close-ish to 500. Now let's look at things. Are we more lung protective now? What's going on? Well, our peak pressure, 16, plateau of 14. Okay, so our peak pressure is lower than volume control. Our driving pressure is still 8. Our static compliance is still 60. Nothing has changed at all. Nothing has changed. The only thing that's changed is basically the flow. Right? Now we have naturally decelerating flow, which once again can be advantageous. And lower peak pressures, which can be a good thing for sure. And now we can do this. We can go ahead and drag out the I time, like in pressure control. Try to get it to baseline. Now we're going to get higher volumes, and in a few breaths, the vent should actually lower the peak. It should actually lower the inspiratory pressure. There we are. Boom. It's lowering inspiratory pressure. So you can get a longer I time. There we go. Now it's lowering it more. You get a longer I time, right? Lower peak pressures, same volumes. So you can see how you can basically use this like pressure control with kind of a volume guarantee. And there might be some scenarios where that is actually beneficial. Maybe you have a patient who likes pressure controlled breaths more than volume controlled breaths, but maybe they're in like a really severe, metabolic acidosis or something, and you want to give them like a guaranteed minute ventilation. Would you use PRVC? Actually, still maybe not, because if they have a metabolic acidosis, let's think about it. They might be very air hungry because they're trying to compensate for that metabolic acidosis. And remember what happens when the patient gets air hungry? The ventilator lowers the support given to the patient, right? So that actually might not be a good scenario. But let's say you have a patient who's snowed. Let's say you have a patient who is, I don't know, they're on paralytics, whatever, and they have that metabolic acidosis. Well, then, yeah, you could use PRVC to get your guaranteed minute ventilation while still dragging out the I time to, increase your mean airway pressure to some extent. But once again, is the patient going to like the flow if they're paralyzed? I don't think they're going to, it might feel more comfortable because, well, okay, if they're paralyzed, they should be sedated too. So really, probably won't make a difference. I guess what I'm trying to say is that I don't really see a scenario where PRVC is really more advantageous, or I don't really see a scenario where PRVC does something that volume control can't do, or that pressure control can't do better. Does that mean that PRVC is inherently bad? No. Once again, you can get that guaranteed minute ventilation while still getting a longer I time and higher mean airway pressure. You can still do that. Our P mean is 8 here, and I think it might have been like 7 in volume control, so we're getting a little more P mean, right, because we're dragging out the I time. So that helps a little bit. Is that a huge deal? No. Is that more lung protective? No, not really. Is that really in any way advantageous? Maybe, but not really in any measurable quantity. Does that mean PRVC is bad? Once again, no. It becomes very bad if they become dyspneic. Now, I can't demonstrate that to you because actually I kind of can. So if I increase the compliance, that is obviously not the same thing as a patient taking in a negative pressure breath, but it can be kind of similar because, you know, the patient is basically contributing to tidal volume generation. So let's see what happens if we try to simulate that by increasing compliance. Now patient's compliance increases. They're trying to take in basically bigger breaths. Right? Volumes are increasing because the patient is trying to breathe over. That's not actually what's happening, but that's what I'm simulating. Now look what happens. The vent starts decreasing our inspiratory pressure. You might even see something kind of like this. The only difference is you'll see signs of dyspnea. You'll see that this waveform is going to look a lot more kind of bowed out. You might see dips or rises in the pressure waveform. It might not be completely uniform. You might look at the patient and they just don't look like a happy camper. But if you look at it, it's going to look like your static compliance is way better all of a sudden, right? You're giving, wow, you know, we're only giving an inspiratory pressure of 5 and we're getting this huge volume out of it. Or not huge volume, but we're getting, you know, a good sized volume out of an inspiratory pressure of 5. Wow, their patient's lungs must be so good. Well, maybe they're just dyspneic. Same thing, let's go the other way. Now here's our limits. I think Hamilton is 5 below. High pressure limit is where it starts to alarm. So let's see, a patient's compliance is worsening. Is PRVC going to be more lung protective than volume control? Let's see what happens. All right, I'm curious. I'm really curious to see what happens. Tidal volumes are dropping. The ventilator is slowly increasing peak pressure. It is really taking its time, though. It's taking several breaths to increase peak pressure. That blue line right there is the pressure limit. Now we can see... Uh-oh, what's going on? We're pressure limiting, right? So Hamilton, 10 below high pressure limit is where it will actually limit it. Now let's see, are we being, well, our tidal volumes dropped a lot. Are we being lung protective? Well, our plateau is 30. That's good. Our driving pressure is 25 though, that's kind of bad. So are we being lung protective? Not really. And we're also not meeting the tidal volume. We're not meeting the tidal volume anymore. If we want to meet the tidal volume, what we have to do is go in here and crank this up more. Because we have to get that guaranteed tidal volume, right? And we're still not hitting that. But we're closer, right? Our minute vent is, you know, something. Now we have a plateau of 40 and a peak of 35. Uh-oh, is that lung protective at all? No? Well, let's see about volume. Maybe volume control's way worse, right? Maybe volume control's way less lung protective. Let's do the same settings. Once again, I'm going to lower eye time. Volume 500. Once again, we'll set our peak to 40. Well, let's see what happens. Oh, we're hitting the peak pressure. We're hitting the peak pressure alarm. We're not getting our volumes. Now, here is the difference. We are hitting the peak pressure. Our plateau is now 35 and our driving pressure is 29. Ooh. So actually, pretty much on the exact same settings, we are at higher driving pressure. But the only thing that changes that is this. And so if we lower it to, like, say 30, actually it had to be 35. We lower this to 35. And now look, we are at the same place that we were on PRVC. Is this less lung protective than PRVC? I mean, I guess if you don't pay attention to peak pressure alarms, I guess it kind of is. But is the ventilator actually doing anything meaningfully different that is changing anything about driving pressure or static compliance? No, it is not. Once again, if we switch, look, 12.1 static. Let's switch back to PRVC. Let's see if that makes a difference. We now, of course, have to put our peak pressure, our high pressure alarm back to 40. What is our static compliance? It's the same. What is our plateau and our driving pressure? It's the same. We are basically at the same point. The only thing that has changed is the peak pressure alarm. The peak pressure is lower, but the plateau and the driving pressure are exactly the same. No difference. Anyway, everybody, that's going to do it for today's video. I hope you learned something. Once again, I'm not trying to vilify PRVC, but I'm also not trying to praise it either. It is a mode that I believe can be used in some circumstances. Do I think it's the best choice? No. Do I think it's the worst choice? No. No mode is the best or the worst. It just depends on your actual settings and what you do with it, okay? Anyway, that's going to do it for today, guys. I hope you learned something, and I hope you have a nice day, and I'll see you all on the next one.